be used along with ketogenic diet. And at the end, whenever you're logging out and not coming back for tomorrow, or if you're going to come for both the day sessions, before you log out, please go and complete the questionnaire, because the ILAE would love knowing your feedback. Okay, thank you very much. And we will come back at 12:20. So it's actually only 6 minutes. Bye, everyone.
I'm Dr. Anaita Udwadya Hegde, and I have with me Roshan Kore. We are the ketogenic diet team. We have other members as well. We're just 2 of them. And as no ketogenic diet program can work without coordination and communication between the physician and the dietitian, likewise, I think Roshan would be a very appropriate person. So Roshan is going to take the talk today on side effects and monitoring of the ketogenic diet.
Thank you, Dr. Anaita. So today we are going to cover the baseline monitoring that is done in the ketogenic diet, the monitoring and side effects during initiation, the monitoring and side effects during the continuation of the ketogenic diet. So our references are Epilepsy Open, the study published, Optimal Clinical Management of Children Receiving Dietary Therapies for Epilepsy by Dr. Eric Kossoff et al. The Ketogenic Diet Guidelines for Infants with Refractory Epilepsy by Alice Vanderloo et al. And our experience with the 300 patients we have seen over the last 10 to 15 years. So starting with the pre-ketogenic diet treatment evaluation, we strongly advise a clinic visit prior to initiation of the ketogenic diet. The goal of the evaluation for pre-KDT is to identify the type of seizure.
It's the same. Well, sorry, the view when it opens. Okay, I'm gonna.
Sorry, I think
just,
someone unmuted.
Okay.
Can we just go ahead?
So, yes, pretty much everything looks the same, but yeah, it's black. It's still selected. It shows the advance with the you know what the other option is? I wonder. Well, only one person can share. It's interesting because there is a share audio option. Yeah,
I looked upon that computer audio can be shared, and even I thought about it, that if the speaker can just share the video and we can share the audio, but then if we'll have to be sure that we both are starting at the same time, otherwise
right,
we go back and forth. So that's again a problem.
Dr. Nathan, we have these other.
Optimized for video.
Yeah,
but yeah, the share sound and the optimized for video clip are both they're grayed out still on the app.
ILAE. They were trying to put it right. So, I don't think they're able to do it.
But can we ask them?
Yeah, that is the same.
Is it happening?
Yeah, Alicia.
So in the webinar,
okay,
so I
just
have
go ahead.
In general on our
it's
webinar page, but then for
Alicia,
the webinar that's happening, I can't
Alicia,
edit any
yeah, Alicia.
I can either join it or end it. Those are the only 2 options.
No, we can't do that because we don't know from where the participants are.
But,
so I think
this is exhausting than the webinar itself.
I agree.
Yeah,
I will say I did not.
Alicia.
Dr. Nathan, I don't think they can hear you.
I don't. Audio.
You can send her.
Yeah, and the.
Alicia, I think would you?
I'm sorry, I'm looking at the settings for another one right now.
I think you will call them, sir.
And there's nothing that would allude to the idea that you can't play sound. None of the settings in general have anything about that, So I don't. Hello. Hi, it's Alicia.
Yeah, no, we are picking you up on the
We try and do this in the afternoon when we have the lunch. Hello. Yeah. Okay. Okay. Bye. Yeah. Sorry for that. You go ahead. I've asked the ILAE not to.
Thank you, Dr. Nathan. So let's resume the talk. We were talking about the pre-KDT evaluation, and the goals is to identify the seizure types. So since morning, we have heard over and again that there are different types of seizures which benefit up to a different level with the ketogenic diet therapy. So also it is required to rule out metabolic disorders that are contraindicated for the ketogenic diet treatment. Evaluate for complicated comorbidities, review all current medications to determine carbohydrate content and options of switching to lower carbohydrate preparations before we start the ketogenic diet, and ensure that caregivers understand their critical role in administering the ketogenic diet treatment thoroughly, because this is what will make or do the treatment. The recommendations for pre-ketogenic diet treatment evaluations we can begin with the counseling part, where we discuss seizure reduction, medications, and cognitive expectations, potential psychosocial and financial barriers to the use of ketogenic diet treatment, review the anticonvulsants and other medications for carbohydrate content, and recommend family read the parent-oriented ketogenic diet information well, so that they understand exactly what we are going to do and how it is going to pan out. The other part is a nutritional evaluation, where we do the baseline weight, height, and the ideal weight for stature. Head circumference is done for infants. Body mass index whenever appropriate. Nutrition intake history is very important. A 3-day food record, which takes into consideration the food preferences of the patient, any allergies, aversions, and intolerances that may be present, is very important. We have to establish the diet formulation. Like for infants, it could be oral, it could be the formulas, or whether it is oral or enteral, or a combination of the two when it comes to the mode of feeding. Decision on which diet to begin with, like do you want to start with the classic KD or the MCT or a modified diet, or you want to use the low glycemic index treatment. Calculations of calories, fluid, and ketogenic diet, or the percentage of MCT oil or carbohydrates per day, is discussed between the dietitian and the neurologist, and this is planned. This is all done during the pre-ketogenic diet treatment evaluation. The KKP ketogenic diet treatment protocol initiation goes on over 3 visits. In the first visit, we give a list of investigations that need to be done before the starting of treatment. We also share a list of equipments and things that the patient will need to start the diet, and a counseling regarding the diet is done in visit 1. Visit 2 will have review of all the investigations that were recommended, checking of the equipments and the things whether they are as required, review of the drugs to make them into a carbohydrate free formulation, explanation of how to chart the seizures, explanation of ketone monitoring, demonstration of the recipes, and a carbohydrate washout diet. Visit 3, where we start with the recipes, the review of the initial side effects is done, and monitoring is re-explained. Any queries that the patient may have had during the period of washout are also sorted out. Laboratory evaluation during the pre-ketogenic diet treatment, there is mandatory and there is optional. So the mandatory evaluation includes complete blood count with platelets, electrolytes to include the serum bicarbonate, total protein, calcium, uric acid, serum liver and kidney test, including albumin, blood urea nitrogen, creatinine, fasting lipid profile.
Definitely I can do, but what happens is that...
And also the fasting sugar, serum acyl carnitine profile, vitamin D levels, vitamin B12 to decide if supplementation is required at the starting of the diet, urinalysis to find out, to see the routine urine, microscopy, calcium creatinine ratio, a renal ultrasound to check on the renal stones, and a EEG. Neuropsychology test may be done as per requirement. The optional tests would include anti-seizure drug levels, if applicable, an ECG, which is strongly recommended if there is a history of heart disease, urine organic acids if the diagnosis is unclear, and serum amino acids if diagnosis is unclear. This is need to know, because as we heard in the earlier talks, that if there is any contraindication, it needs to be ruled out before we start a ketogenic diet. Vitamin A, E, folate levels, ferritin, to decide if supplementation is required. Monitoring and side effects during initiation. Side effects of ketogenic diet treatment often happen, and neurologists and dietitians need to understand them and how to manage them. Adverse effects that are known to occur during ketogenic diet initiation can greatly discourage and cause stress for families. And intolerance is a common reason for early ketogenic diet discontinuation. This is the time when the dietitians and the neurologist or a representative has to be easily accessible to the patient, because that will help them to get over the problems that they are initially facing and help them to give them the confidence that they will be able to do the ketogenic diet in the long term. Transient hypoglycemia, dehydration and acidosis, gastrointestinal disturbances, food refusal, and drowsiness are some of the other side effects seen during initiation. Gastrointestinal disturbances are problems such as vomiting, nausea, diarrhea, and abdominal discomfort. And these are common side effects and seen in more than 50% of the ketogenic diets. Constipation is commonest complication of KT and often present prior to diet initiation. Dietary changes like choosing recipes with larger volume, more fibrous food in the diet like vegetables and whole grains can help to relieve it. Also making sure there is adequate fluid intake. Many children also need additional treatment with medications. We have many times seen patients who had constipation to begin with, but were better off when the ketogenic diet were started in our patients. Children with pre-existing gastroesophageal reflux will have exacerbation by the high-fat content in the diet and delayed gastric emptying. Optimizing anti-reflux medication can be helpful. When the amount of fat is increased gradually and gastrointestinal side effects are seen to be lesser. Food refusal. The reason for food refusal could be nausea, vomiting, pre-existing sensory-related feeding difficulties. It can be very distressing for the parents, as suddenly there are a lot of changes that are happening and the child is refusing to eat, and it can cause a lot of stress. Most common reason for stopping the KD has been food refusal. Management of this is through managing the GER, use of anti-emetic drugs if there is vomiting. We have to adjust the diet texture as per the taste and preferences of the patient for better acceptability. Rice tube or peg feeding can be considered. Hunger. The reason for hunger is that the quantity of feeds are lesser than what the child may be having earlier with a higher carbohydrate intake. Hunger becomes an issue for the parents more than the patients. However, with achievement of ketosis, the patient feels more satiety and this may reduce. Drowsiness is due to hyperketosis. It could be due to hypoglycemia or elevated levels of medication. Hyperketosis is defined as 5 millimole per liter or higher of ketones in the blood. When we do the urine testing, we come to know about it by the 4++ urine ketone levels on the ketodiastics, which is basically when you dip the ketodiastics in the urine, it turns darkest shade of maroon within 10 seconds. Symptoms are drowsiness, rapid breathing, tachycardia, facial flushing, irritability, vomiting, lethargy, and poor feeding. Increased risk of excess ketosis and metabolic acidosis, concurrent use of carbonic anhydrase inhibitors, for example, topiramate and zonisamide. Monitoring of ketones in blood or urine will ensure therapeutic level is reached without risking the symptoms of excess ketosis. Immediate management of hyperketosis can be done with 30 ml of sugar-free fruit juice, preferably orange or sweet lime juice, to provide anti-ketogenic carbohydrate, which will reduce the ketone levels. This can be repeated after 4 to 6 hours if the symptoms still persist. Long-term management includes increased fluid intake and decreasing the ratio to meet the required ketone levels and avoid the hyperketosis. Hypoglycemia, although uncommon in the absence of metabolic diseases, there is always a risk of hypoglycemia during initiation, especially in presence of vomiting and diarrhea leading to dehydration. It is more common if fasting is used for initiation. Then there is a protocol that needs to be followed to check the sugar levels frequently. Symptoms include poor body tone, jitteriness, lethargy, poor feeding, cold and clammy skin, hypothermia, and cyanosis. Hypoglycemia is defined as glucose levels below 2 to 2.5 millimole per liter, approximately 40 milligram per deciliter, and should be treated immediately with 2 to 4 grams of carbohydrate. Usually, a 30 to 50 ml of juice, sugar-free juice, is administered. Long-term management is carbohydrate allowance needs to be adjusted to maintain sugars and get the ketones desired both at the same time. Recommendations by ILAE is that during initiation, blood glucose should be checked twice daily or based on the symptoms of hypoglycemia. Dehydration and acidosis. Liquids, especially water, is difficult to feed in majority of the children with developmental delay. This could be because of sensory issues, added nausea, vomiting, and loose stools. Remedy is to provide enough fluids in the form of flavored water or adding water to the feeds to increase the volume. More recipes with liquid consistency and variety of liquid consistency recipes can also help to increase the water intake. Adding zero carb foods like jelly, which are more solid and become liquid later on, are also a good way to increase the fluid intake. Monitoring and side effects during the continuation of the diet. During this phase, the previous seen symptoms like dehydration, which can occur with incurrent illnesses, hyperketosis, gastrointestinal complaints can still persist. Besides that, growth faltering, nutritional deficiencies, renal calculi, infections, hyperlipidemia, and vascular and cardiac concerns can be during the continuation of the ketogenic diet. Growth. There is evidence of impaired growth in children on the ketogenic diet. Younger children may be more at risk. Long-term follow-up of children treated with the KD in the past suggests that although growth does not improve after the diet is discontinued, height gain can still be below the expected. One retrospective review described 86% with slowed growth, and this effect was not related to age, KD duration, protein, or calorie intake. Monitoring of height and weight at every follow-up will help us to track the growth faltering, if any. Recommendation of protein to energy ratio of at least 1.5 gram protein per 100 kilocalorie has been suggested to help prevent growth faltering. However, if this may be a little difficult to manage if the ketone ratio is higher. Nutritional deficiencies. Children with drug-resistant epilepsy are at a risk of insufficient vitamin D status prior to starting a KD. Decline in both whole body and spine bone mineral content while on KD has been reported. Hypomagnesemia has been also seen. Remedy is correction of the deficiency at initiation as per the baseline investigations and regular supplementation of calcium, vitamin D, multivitamins, and omega-3. Renal calculi. Renal calculi has historically occurred in 3 to 7% of the children on ketogenic diet treatment. Uric acid, calcium oxalate, calcium phosphate, or mixed composition stones have been reported. Risk may be higher with long-term treatment and concurrent use of carbonic anhydrase inhibitors like topiramate and zonisamide. A retrospective study comparing patients treated by KD with or without daily potassium citrate supplement has suggested a preventive effect. Remedy is to use adequate fluids, Daily oral intake of citrate potassium that alkalinizes the urine and solubilizes urine calcium can be suggested to prevent kidney stone. It can be monitored by regular urinalysis and renal USG. Infections. Most common in is the respiratory infections due to the gastroesophageal reflux and microaspirations. UTI is also common. Remedy is to increase the protein intake in the diet so that the child's or the patient's immunity can be improved. Decreasing ratio in the diet can also help. Also, the GER needs to be treated. Monitoring is by checking the urine routine regularly. Urine microscopy is done monthly or initially and then at every follow-up. Chest physiotherapy can help with the microaspirations. Chronic urinary tract infection treatment is helpful. In worst case scenario, we need to stop the diet if the infections are difficult to manage. Hyperlipidemia. Increased serum triglycerides and total and low density lipoprotein cholesterol levels have been reported in 14 to 59% of the cases. But as Dr. Nathan had earlier mentioned, it can be seen as early as first month of therapy and is usually temporary. In one study, 60% of those on the classic KD had hypercholesterolemia by 12 months. The serum lipid values often normalize and remain within normal limits. Strategies to prevent KD-induced hyperlipidemia include proper combination of the PUFA, MUFA, and saturated fats, supplementing with omega-3 fatty acids and carnitine, decreasing the intake of trans fat, saturated fat, and cholesterol, decreasing the ketogenic diet ratio. Vascular side effects or complications. Although the risk for coronary artery disease may increase with long-term elevations of cholesterol levels, previous pediatric studies showed no change in the carotid intima media thickness compared to baseline at 6 and 12 months of therapy. On the other hand, local and systemic arterial stiffness was significantly increased in 2 studies involving children and young adults, correlated with serum cholesterol and triglyceride levels. Cardiac abnormalities have been reported in children on the KD, including cardiomyopathy and prolonged QT interval. The mechanism of this complication is not fully understood. Selenium deficiency has been postulated, and we can think of the selenium, giving selenium as a supplement. Clinical monitoring during follow-up. So there are parameters on which this can be done. I will discuss the recommendations that have been given and what we follow in our KKP protocol. Assessment of KD efficacy by seizure, diary, and medication review. Also, any other observed benefits. It is recommended that it should be noted down at every follow-up. We do follow that at every visit. Assessment of KD tolerance and side effects, including questions about bowel function, sleep behavior, and appetite, should be done every follow-up. The KKP protocol does it at every visit. Weight, height, and head circumference. Recommendation is every follow-up visit. Same followed in the KKP protocol. Renal ultrasound. The recommendation is that after 12 months on the KD, it should be done as an extra test if clinically indicated by hematuria in 3 consecutive tests, or if an infant shows unexplained irritability. In the KKP protocol, it is done at baseline and at every 12 months and more frequently if clinically indicated. EEG is recommended to be done every year. The KKP protocol does it every 12 months. ECG is done at baseline and if clinically indicated as per the recommendations. The KKP protocol, we do it only if clinically indicated. Biochemical monitoring during follow-up. The laboratory investigations like full blood count, renal profile, etc. The recommendation is to do it 6 weeks, 3 months, 6 months, and then every month. We usually do it every 12 months and in between if clinically indicated. Vitamin D lipid profile, free and acyl carnitine profile is recommended to be done every 3 months, 6 months, and then every 6 months. The KKP protocol does it every 12 months and frequently if clinically indicated. Urine routine microscopy. And urine calcium by creatinine ratio is recommended to be done at 6 weeks, 3 months, 6 months, and then every 6 months. The KKP protocol follows urine routine and microscopy at every follow-up, whereas the urine calcium and creatinine ratio is done at every 12 months. Vitamins A, E, B12, zinc, selenium, copper, and folate and ferritin is recommended to be done every 6 months and then every 12 months. We only do the B12 and vitamin D, and later on it is followed up at every 12 months. To sum it up, let's go by the timelines. So during the pre-ketogenic diet treatment, the clinical monitoring is done, review of seizures, drugs, EEG, MRI, dietary review is taken, counseling regarding diet is done. The lab investigation during this period are as mentioned here and we had discussed earlier. During initiation, side effects like gastrointestinal side effects, constipation, food refusal, hunger, drowsiness, hyperketosis, dehydration, acidosis, and hypoglycemia may be seen. During this period, monitoring is done of CBC, renal and liver profile, calcium, phosphorus, vitamin D, urinalysis, EEG, sonography, lipid profile, acyl carnitine profile. During continuation, side effects like hyperketosis, dehydration, gastrointestinal side effects, growth failure, micronutrient deficiencies, renal calculi, and intercurrent infections may be seen. To conclude, awareness of side effects and regular monitoring according to a fixed protocol makes the ketogenic diet journey easier for the patients, relatives, doctors, and the dietitians. And doing this will make the ketogenic diet much more compliant and successful. The KetoKit project team includes Dr. Anita Udvadia-Hegde, Dr. Shilpa Kulkarni, myself, Ms. Bhakti, and Ms. Suvarna. And we together try to implement all the recommendations of the ketogenic diet treatment as much as possible. Thank you.
Thank you, Mr. Roshan, for this nice presentation and concise one about the pre-ketogenic diet evaluation, side effects, and monitoring. It's a great pleasure to be with you all today. I'm Dr. Omnia Rashidi from Egypt Pediatric Neurology. I have to introduce you first, but I think Dr. Anita introduced you very well. You are the senior manager and senior dietitian in the SRCC Children's Hospital, and you have a very nice CV in coordinating pediatric neurology rural camps with Dr. Anita. And it's great pleasure to hear you. And I will going to have the Q&A at the end of the session. Now I introduce Mrs. Siddika Panjwani. She has a Master of Arts in Clinical Psychology, and she's interested in neuropsychology and have a special experience in cognitive rehab. Her talk today will be about the effect of ketones on cognition in epilepsy. Thank you so much. Dr. Siddika?
Omnia?
Yes?
Can you hear me? The next speaker will take a few minutes to join. So can Dr. Sumita start hers? In the meantime, Sumita, can you start yours? There's a problem.
Yes, I'll try to share the recorded version and see if that works.
No, it won't. It won't.
It won't,
The
okay.
ILAE is still not able to put things right. So we've got an expert from our side to try and put it right. Oh, okay, doctors. Sumita, Siddika has come in.
Okay. Hi.
So I think you can wait. Siddika, will you play your PPT and speak live?
Yes, I'll do both. I'm just opening my PPT and sharing my screen. Okay. Can you all see my screen?
Yes.
Okay. Hi, good afternoon. I'm Siddika Panjwani. I'm a clinical psychologist working in the field of neuropsychology for last 20 plus years. And I have been regularly doing assessments for a variety of neurological conditions with Dr. Nathan and in other hospitals, seeing people with epilepsy, head injury, stroke, dementias, etc. So today the focus of my talk is ketogenic diet and its role as a cognitive enhancer or its role in cognitive functioning. The talk is predominantly based on literature review with some experiential data that I have had over the years with my assessments. So what is to begin with, what is cognition? So cognition is anything that we would term as higher brain functions. So memory, attention, language, visuospatial ability, all of these would comprise as cognition. So anything that my brain processes in terms of information, consolidating it, retrieving it, would all be termed as cognition. In any neurological condition or insult, cognitive abilities get impacted because there is possible tissue damage, damage to the neuronal networks, or an imbalance of the neurotransmitters in the brain. Cognitive decline could be rapid or gradual based on the condition that the individual is having. So something like Alzheimer's disease would have a more gradual progressive decline, whereas something like a stroke would be a more immediate rapid decline. How does KD play a role or ketogenic diet play a role in cognitive decline? So the first article that I'm going to present will explain the neurobiological mechanisms. The second one will focus on epilepsy, and the third one will focus on dementias. So the whole premise is that glucose is our core source of energy. However, in neurological conditions like dementia, we are unable to metabolize glucose effectively, which leads to cognitive concerns. So ketogenic diet would or ketone bodies would provide as an efficient alternative fuel to compensate for this glucose hypermetabolism, and in the bargain promote cognition and tackle the disease progression. So the first article that I came across, it's a article that's done on rats, but it explains the neurobiological mechanisms very effectively. So what they did in the study was that they looked at the neurobiological patterns or dysfunctional patterns in the hippocampus and prefrontal cortex of rats as they were aging. And what they found is that, as we were talking earlier, the glucose metabolism pattern was impacted. So they were looking at dietary therapies that could probably bypass this need for neuronal glycosis. So they trained the rats to perform a task of working memory and also a biconditional task. Now, the rats that were given ketogenic diet definitely performed better on these tasks over a period of time as compared to rats who were given a more carb-rich diet. Saying that ketogenic diet does play a role in terms of improving cognitive abilities by providing an alternative fuel source. The second article that I came across was a systematic review of multiple studies that have been done with ketogenic diet and epilepsy. And what they found is that not just seizure control, which is the primary reason why ketogenic diet is used in refractory epilepsy, it also shows positive effects on cognition of adults and children who are treated with KD. So this was the slide where they had done an analysis of all these studies. And what they found is that amongst the domains assessed, alertness showed a consistent pattern of improvement across studies, and which has been our experiential data also over the years, that alertness and awareness of surroundings definitely improves post-seizure control and with children on ketogenic diet. Another thing they did was they compared studies which use the modifying Atkins diet as compared to studies that use the classical ketogenic diet. And definitely the improvements with the classical ketogenic diets has been higher as compared to the modified Atkins diet. So possibly the number of ketone bodies that are produced and the mechanism of the diet both play a role in terms of showing better cognitive outcomes. The third thing they analyzed was to see how it worked for infants, children, and adults. And what they did see is that adults showed relatively more improvement as compared to infants and children. Albeit the sample was small, the studies are few, but possibly the reason for this is that in adults, they have had some period of normal development before the seizures started. As a result, when the KD shows good seizure control and there has been an improvement, it does go back to some degree of normal development, which was present pre-morbidly. However, in children, if the seizures have started early in life, there has not been a span of normal brain development, which is why even in our experience, when we evaluate children on tests of IQ or developmental quotient, we do not see a remarkable change in those scores. The alertness goes up, the behavior is better, the seizure control is better, but because the brain has never seen normal development, it's not able to improve as much. So this was about epilepsy, and the final article that I read through, or I have put it up for discussion, is they had done an evaluation of people with degenerative brain conditions and seen the implications of ketogenic diet. So most of them have used ADAS-COG as an instrument of assessment. Couple of studies have very good sample size, but most of them have small sample size. And they have predominantly used MCT, because using KD in a population which lacks insight, which is unwilling to follow dietary restrictions, is challenging, which is why MCT could be an option, is what they are postulating. And across studies, there has been some degree of improvement on the ADAS-COG score, which shows that even MCT per se is able to make some degree of difference in terms of cognitive abilities. The limitations are none of these are double-blind randomized control trials. Most of them are open studies. So the results do need to be taken with a bit of caution. But yes, the graph points towards a positive direction. So in conclusion, definitely KD seems to be showing beneficial cognitive effects across neurological conditions that we are seeing. And there is some degree of neuroprotection that it offers across age groups. Thank you so much.
Thank you, Ms. Siddika, for this excellent presentation, which increased our alertness and cognition about the effect of ketones on cognition in epilepsy. And we shall receive all the Q&A at the end of the session. And now I introduce Dr. Sumiza Margishu from Malaysia. It's a great pleasure to be with you, our coming pediatric neurology stars. She has the MRCP from the Royal College, and she has been working as a pediatric neurologist from 2019 till now in Malaysia, and she has spent 1 year in Japan as a fellow in epileptology and clinical EEG. Her talk today will be about the nutrient supplement and concomitant medication for comorbidities. Thank you.
Thank you very much, Dr. Omnia. I'm going to try to share my screen.
Okay.
Okay, can you see my screen?
Yes.
Okay. I'm going to get going. So I'm going to speak to you about the nutritional supplementation and medication. 1 second, sorry. Okay, so these are the topics that I'm going to cover. Nutritional deficiencies while on the ketogenic diet, a little bit on the assessment and monitoring. I think the previous speakers have spoken about them. Specific considerations with regards to calcium, citrates, vitamin D, carnitine, selenium, and essential fatty acid. I probably won't speak so much about that. And carbohydrate in medication. So the first question is, why is there a need for supplementation? So we know that the diet is extremely restrictive, especially when it comes to multivitamins and minerals, calcium, and vitamin D. On top of that, the risk of nutritional deficiency is often increased by pre-existing feeding problems and also the effect of several anti-seizure medications prior to the use of the diet, including folate antagonists. What is the evidence with regards to the nutritional deficiency on the ketogenic diet? Not many, often they are just case reports. So I think the earliest I picked up was in 1979, a case report on optic neuropathy. And in the very same year, vitamin D deficient osteomalacia and decreased bone mass. Later in 2003, several case reports with regards to selenium deficiency associated with cardiomyopathy. In 2006, there were reports on carnitine deficiency, as well as scurvy in 2008. And in 2021, the one in 2021 was a child with autism on the diet. And in 2010 and 2011, there were case reports on pellagroid dermatitis. This was one paper, a systematic review that looked at the effect of the classical and the MCT diet with regards to vitamin and minerals. So this is a systematic review in 2012, children aged between 2 to 16 years of age, whereby they measured the levels of vitamin A, E, zinc, and selenium and magnesium at baseline, 3, 6, and 12 months respectively. So the levels of A and E is fairly variable. Not much change in zinc was found. However, there were low levels of selenium and magnesium. We move on to nutritional assessment, just very briefly, as I think Roshan had spoken about it very well. So it's extremely essential at baseline and throughout the treatment with a good and thorough dietary history and appropriate supplement type and compliance. We should aim to provide the recommended nutrient intake for vitamin and minerals. I think the dietitians are fairly familiar with these terms, and consider using the height age rather than actual age in children who are extremely small. And laboratory assessment and nutrition focused physical findings, I think this is important to us as clinicians. It's about examining the patient, look for nutritional deficiency, and it's ironic because often the appendages are affected. So I will spend a bit time on the nutritional focused physical findings in the next few slides. So we start off with copper deficiency. Copper deficiency can present with anemia. So you might have a patient who's pale, palpitation, unexplained tachycardia, neutropenia, frequent bouts of infection or increased risk or susceptibility to infection, and a very abnormal hair texture, dry and coarse, and depigmentation of the hair and skin. Below are the food sources of copper, including cashew nuts, almond, leafy greens, and dark chocolate. Magnesium deficiency can present with loss of appetite, nausea, or vomiting. They can have fatigue and weakness and muscle twitching and cramp. Food sources of magnesium include seeds, nuts, cocoa, and beans. Vitamin D deficiency can lead to bone and joint pain, muscle cramp, and bone loss. So an unexplained trivial fall causing a fracture should make us think about the possibility of loss in bone mineral density causing a fracture. And below are the sources of vitamin D: oily fish, liver, and egg yolks. Vitamin B3 is also known as niacin, and it is characterized, the deficiency of B3 is characterized by the triple D, which is dermatitis, diarrhea, and dementia. The dermatitis is often called a pellagroid dermatitis, was reported in the case reports, and they often thicken, dry, scaly-looking skin. And food sources of vitamin B3 include red meat, poultry, fish, brown rice, nuts, whole grain, and avocado. Vitamin C, or the deficiency commonly known as or referred to as scurvy, can present with mucosal bleeding, gingivitis, and loose teeth. They can have rough and very dry skin, and they have prone susceptibility to infection. Food sources of vitamin C include green leafy vegetables, bell pepper, broccoli, and strawberries. Selenium deficiency is rare. It can be characterized by thin and brittle hair, scaly skin, and rarely cardiomyopathy, a weak immune system, and anemia. Below are the food sources of selenium: eggs, tuna, and seeds. Finally, zinc deficiency often can present with growth retardation, loss of appetite, or impaired immune function. What's more characteristic about zinc deficiency is diarrhea and also impaired wound healing with open sore on the skin and a term called acrodermatitis herpetica. And food sources of zinc include the following: eggs, oyster, peanuts, liver, milk, beet, and salmon. So these are the clinical monitoring and recommendation by the International Ketogenic Diet Society in 2018. I won't go into the details of them, as I think the previous speaker has already gone through them. So we start off with the universal recommendation of with regards to supplementation that includes vitamin, including trace minerals and selenium. And this is the brand of multivitamin which is available in our hospital, which we prescribe to our patient. And this is the different components of the multivitamin in comparison to other syrup, other vitamin types. And you can see that it consists of all the vitamin B and all the vitamin A, C, D, and E, including micro minerals like folic acid, calcium, copper, iron, iodine, magnesium, phosphorus, phosphate, and zinc. Unfortunately, this does not contain selenium. So often parents find that the multivitamin tablets are unpalatable, and can they buy other products over the counter? The answer is yes. They may be more palatable, but remember that they must be low in carbohydrate. So often powders and tablets and capsules are preferred. And you must ensure that they provide full requirement, including calcium and iron. And sometimes more than one product is needed to meet all the vitamin, mineral, and trace element requirements. So we move on to vitamin D and bone health. So why is there a risk of poor bone health in epilepsy? That is because there's a 2 to 3-fold greater risk of fracture than the general population. And 35% of this fracture is directly attributable to seizure activity. It is also because of the prolonged use of anti-seizure medication, or the direct and indirect effect of the anti-seizure medication on calcium and vitamin D metabolism, and other comorbidities conditions that affect weight bearing. So the diet contributes to this risk because chronic ketoacidosis increases the demand on bone mineral for buffering capacity, and it causes alteration to the vitamin D metabolism. What do the studies on the effect of ketogenic on bone health say? So there was one study that looked at the diet causing progressive loss of bone mineral content in children in a 15 months follow-up. So they were prescribed vitamin D and calcium supplementation despite reduction in the number of anti-seizure medication use, and they found that there was a decline of 0.6 standard deviation per year. There was a case series with regards to patients of GLUT1 deficiency who were treated with the diet for more than 5 years. The report was on 3 adults, all women aged 24 to 25, and they found that there was no adverse bone effect. And a prospective longitudinal study of 29 children aged between 3 to 18 years on the diet within 6 months to 6.5 years and they analyzed the calcium levels at baseline and every 6 months, and they found there was an average decrease in bone mineral density of 0.16 standard deviation for every year they remain on the diet. Bergovitz in 2021, this is quite a recent article, came up with a narrative review and said that there is no human clinical studies to determine if the diet therapy derives positive or negative effects on bone health. However, there are many risk factors, including the anti-seizure drugs, reduced mobilization, the ketogenic diet itself, and therefore concluded that we should be aware of potential skeletal side effects. So the recommendation guidelines suggest that be aware of potential skeletal side effects, optimize calcium and vitamin D intakes, supplement vitamin D based on blood levels, and vitamin D3 or cholecalciferol is recommended. Monitor the bone health during the diet to minimize potential and long-term negative health consequences. And bone mineral density scans after 2 years on the diet is optional. This is not something available to us, so we do not do them. We supplement all our patients with multivitamin, which already contains vitamin D, and we also supplement them with calcium. We move on to selenium. This was a paper in 2018 that looked at the ketogenic diet on serum selenium levels in patients with intractable epilepsy. Of 54 patients on the classical ketogenic diet of 2:1 and 3:1 ratio, they found 49% of them were diagnosed with selenium deficiency. And selenium deficiency and cardiac dysfunction was reported in 3 cases. As I've stated before, the dietary sources of selenium include meat, seafood, eggs, and dairy products, but there was no clear advice about resupplementation. So it's suggested to check if it's available in the multivitamin, and to check the levels at baseline and follow up. Oral citrates or urine alkalizers. So there are class 3 evidence for its prophylactic use. There was a retrospective study that showed the risk was reduced 3-fold with the use, initially solely just based on urine calcium to creatinine results. This subsequently led to a study evaluating the empiric use of oral citrates for all children on the diet, which led to a reduction in incidence from 6.7 to 0.9% without any adverse effect. 56% of the consensus group, I'm talking about the International Ketogenic Diet Society, routinely use empiric oral citrates for all children. That's not the scenario on our side. We regularly monitor them for symptoms, and we do ultrasound, kidney, urinary, and bladder for 6 months. If they have symptoms or if they have stones, then we provide them with urine alkalizer. Carnitine. I think many of us have spoken about the role of carnitine in fat metabolism. It's essential because it facilitates the transfer of long-chain fatty acid into the mitochondria, and it is increased need with high fat intake. Also, there's an increased risk of deficiency if drugs like sodium valproate is used along with the ketogenic diet, and the concerns are often more related to the classical ketogenic diet. So the carnitine level often declines initially, but subsequently stabilizes. The deficiency can lead to impaired energy level or a drop in ketosis. So this is something to think about. If you're at good ratios, despite being on good ratios and good tolerability, and you're not getting good ketosis, then you might want to consider looking at the carnitine levels. The symptoms of carnitine deficiency include decreased muscle strength, excessive fatigue, and generalized weakness. However, clinical signs of deficiency are often very rare. So it's recommended to measure both the free and total carnitine levels at baseline and do regular blood monitoring, and only supplement if the levels are low or the children are symptomatic, and always start at a low dose at 10 milligrams per kilo per day to avoid adverse effect. The majority of the ketogenic diet center, 84%, recommend that carnitine should be supplemented orally only if levels are low or the child becomes symptomatic, which is similar to the 2009 consensus. We know the diet can cause a lot of gastrointestinal side effects. So often patients can have either a reflux or a gastroesophageal reflux disease or constipation. The use of empiric use of supplementation has not been studied, and we do not give our patients, or we do not treat our patients empirically with proton pump inhibitors or H2 blockers or medication for constipation. We only treat them if they are at high risk or they have symptoms. These are the following medications that we often use. They are either tablet form or rectal suppository form. We never use syrup medication because the sugar content in elixir and syrups are very high. There is no current evidence with regards to the use of probiotics. I think there are a lot of studies still ongoing, omega-3 fatty acid or exogenous ketones, which are highly popularized by athletes. We'll come to the topic of carbohydrate in medication. Remember that all medication must be reviewed before commencing the diet and at each clinic visit. If possible, change them to the lowest carbohydrate version of medication. If they cannot be changed, then they must be included or calculated into the diet. Tablet versions usually have a lower carbohydrate content compared to syrups, liquids, and elixirs and chewable tablets, and medication in suppository form are suitable. And also, the carbohydrate content of individual medication can vary depending on the manufacturer, so try to use the same product whenever possible. Finally, this is the committee's conclusion that all children should receive daily multivitamin and calcium with adequate vitamin D. Oral citrates appear to prevent kidney stones, but there is a mixed opinion on empiric use. Vitamin D levels decrease on the ketogenic diet. Again, there are split opinions on the empiric extra supplementation, and there is no recommendation for the use of antacid, laxative, probiotics, exogenous ketones. So I conclude by saying the diet can be very restrictive and it requires careful assessment, implementation, and monitoring. Supplementation is necessary to prevent nutritional deficiency and only give necessary supplements and monitor compliance. Thank you very much for listening.
Thank you so much, Dr. Somiza, for this fruitful presentations with clear up to us what are the supplements to be given routine for patient of ketogenic diet and what are the options for that. I think now we can go to the Q&A. And we could start with Ms. Roshan. And it can be, I think it is, what is the dose of potassium citrate is optimal to be used? Ms. Roshan or Dr. Anita?
So we usually, I'll be honest, just like Sumita, we do not use potassium citrate in all our patients like prophylactic. We monitor them when we see there are calcium deposit or if there are symptoms, we definitely start it, but I use it in all patients with topiramate and zonisamide. So if a patient,
you are muted.
No, I'm not muted. I'm not muted. Hello? I'm not muted.
Yes, you are not muted. I can hear you. Okay.
So we use it in patients who are zonisamide and topiramate or symptomatic, or if the urine shows something. We usually give them a 5 ml twice a day, and in older children, I would go to 5 ml 3 times a day. I think 5 ml is roughly equal to about 6 or 7 milliequivalents, and it's roughly 1 milliequivalent per kg per day.
Thank you. Dr. Somiza, you have any comment about this question?
No, similar, but we use something known as a Ural sachet, which is predominantly used in the adults. So we use probably half a sachet 2 times a day or 3 times a day.
Okay, it's for Egypt, we use it as a routine because we have done a research and we found mostly all patients have high calcium creatinine ratio due to our hot climate and the decreased supplementation with water for these children. So we use it again in the same doses you said, but we use it as a routine. The second question again, Dr. Anita and Rosham, how do we go with the wash of the diet before starting ketogenic diet?
Okay, so washout diet is followed as a initiation when the diet is done on the OPD level, where we do not follow fasting, but we want the carbohydrates to be kind of washed out from the system. So we follow a diet which provides around 10 grams of carbohydrate throughout the day. During this phase of 5 days, we restrict all foods which are high in carbohydrate like cereals, grains, pulses, fruits, milk. We make a diet which would have approximately 10 grams of carbohydrate, and that way the ketones will come higher faster. And then we transition the patient on the day 6 on the regular ketogenic recipes.
Okay, that's very good. And again, they continue the question, how much MCT can be considered safe, and what is the highest dose of the MCT on the other side to be incorporated in?
I would defer this answer for later, because I think we have a session on MCT-based ketogenic diet. So I'm sure they will cover that.
Okay. The third question is, shouldn't hypoglycemia treated as emergency by giving add sugar? I think this is a very, very common mistake which have been done all over the world for thinking about hypoglycemia and giving sugar.
Yeah, so what we do is that actually we need to understand that hypoglycemia that happens in a patient who is diabetic is different and not that severe in a patient who is on a ketogenic diet.
Yes.
So initially there could be hypoglycemia, but treating it with 2 to 4 grams of carbohydrate in the form of a juice would very well help to elevate the sugar levels around up to 100 milligrams per deciliter. And as we start the feeding, slowly and steadily, the sugar levels will stabilize. So this is our experience. And basically, we need to understand that you do not need to be panic so much, or treat it like a diabetic patient.
Yes, it's very, very important point for all physicians when they encounter with a patient on ketogenic diet. Oh, he's hypoglycemic, I must give sugar as soon as possible. No, never give sugar. Never give oral sugar in water. Never give IV glucose. If you do that, the patient will go to convulsions. He will start convulsing if you do that, because you turn the key for epilepsy, as we see. So as you said, it's a very, very important point. This is for Dr. Anita. How often you monitor urine ketones?
So ideally, if the patient is on the classical ketogenic diet, we monitor the urine ketones 4 times a day. If they're on the modified Atkins diet, we may ask them to do 1 ketones a day, which is random. So it's not always morning, not afternoon. Some could be morning, some could be afternoon. So we get a rough assessment of them. But if you're on the classical diet, particularly in the beginning period, we tend to be a little rigid and say do it 4 times a day.
Okay, that's yeah. Again, I think it's different according to the start or during initiation and along when you go to the maintenance. I think this can differ how much also.
Yeah. Once they're in regular ketosis, the patient is comfortable, the mother has understood the diet properly, then we give them a little, a leeway to be a little less rigid on it.
Yeah.
But when you are teaching it, I would say teach it correctly so that they do it, and then they can, step down as time goes by.
Yes. This is for Ms. Siddika. How do you apply animal study cognitive assessment? Rats, how rat is cognitively assessed?
So they had tried a maze task on the rats to teach the rats about working memory and also the biconditional task. I will share the articles with Dr. Nathan and he can share it with you all. It's a very interesting article because for humans, it's difficult to pull out neurobiological substrates because you can't dissect humans. But definitely for neurobiological studies, I don't think we have an option other than animals. But it's a very interesting study using maize and how the rats did better actually.
Thank you so much. And the coming question for Dr. Sumita. What is better to use gross monitoring children on ketogenic diet, IAP percentile chart or WHO Z scores, and the scope of body composition analysis on ketogenic diet patients?
Sorry, Dr. Omnia, can you repeat the question?
What is better to use, the gross monitoring charts for patient on ketogenic diet? Which gross chart you use? IAP percentile or WHO Z score?
Yeah,
for monitoring?
Sorry, we use the WHO scores, yes.
That score. And the body composition analysis? You do body composition analysis for patient your ketogenic diet?
Body composition analysis meaning?
I think this is used for adults. You know, it's not, and then I think our dietitian and clinical nutrition can answer this question, because I really see it in adults. So I think not in children.
Yeah. I think the dietitians might be a bit more familiar. I'm not familiar with the body
Roshan,
composition.
do you?
Composition based, the body composition, I think the person whose question is asking about whether we monitor the body fat, muscle, and mass and all that. But we in our protocol do not use the body composition. We just use the IAP height weight charting, and if possible or required, then we might do the BMI.
Okay. Again, I think Dr. Sumita, do you recommend probiotic sources included in classic ketogenic diet routinely?
So I think, like I said, I think there are a lot of work going on, but there's not enough evidence yet. And I have no practice of using probiotics in children on the diet.
Dr. Anita and Roshan, you have any comment about that?
We don't use probiotics routinely for children on the diet.
I think it's one of the action or mechanism of action of ketogenic diet is through intestinal microbiota modulation, and it is a good source by itself to improve probiotic in the intestine. I think so. Again, they are asking, how do you advise parents to be aware of hyperglycemia in monitoring blood? I will repeat the question again. How do you advise parents to be aware of hypoglycemia? Yes, I think, Roshan, they want to know what are the signs of hypoglycemia.
So to clarify, hypoglycemia would not be very common when you are not doing fasting for the patient during initiation. And if you are doing fasting, the child would usually be in a hospital where it will be closely monitored by the doctors. At home, really not very frequent. I haven't seen any of my patients having hypoglycemia. But if you need to find out, you would know by the symptoms of hypoglycemia. Like you all know, it's excessive hunger, jitteriness, sweating, cold hands and extremities. But we do not need to advise, or we do not advise blood monitoring frequently on a ketogenic diet to check on hypoglycemia. It doesn't happen very frequently.
Okay. The last question for Dr. Sumita, is the ketogenic diet can be used for non-epileptic movement disorder in children?
I have no experience with the use of ketogenic diet in other conditions besides epilepsy. So mine is just all refractory epilepsies.
Dr. Anita, you have any comments?
So yes, I will cover a little bit of it tomorrow. There are many conditions today. Once we have genetics, many epilepsies have movement disorder epilepsies with them. So a large chunk of genetic epilepsies may have disorders with them. I think you will see that the ketogenic works well for the seizures, but doesn't work that well for movement disorders. So while it may be tried in some of the conditions which have associated movement disorders, the outcomes are not that beneficial for movement as it is for epilepsy.
So am I think so, but I didn't try it. The third question, I don't know if you tackled the coming question, if it has been tackled before in previous session. How effective keto diet on infantile spasm? I think Dr. Anita, Dr. Somiza can comment.
So we use the ketogenic diet on spasms quite often. So if they fail my steroid, if they fail my vigabatrin, and if they fail 2 of my drugs, topiramate, nitrazepam, or 1 of the 2 of the drugs, I am happy to put them on the ketogenic diet earlier than later. This is obviously a change in thought process over the years. Initially, like everyone else, I would wait for longer, but now I use it a lot earlier. Infants getting ketosis is a little sometimes tougher because we don't use the ready-made powders. Cost is a huge concern in our country for the ready powders. So getting proper ketosis sometimes is a little tougher, but I routinely consider it for infantile spasms with good outcomes. I'll be honest, with good outcomes.
And for you, Dr. Somiza?
Likewise, I think we're also trying to be a bit more aggressive. So when they fail the vigabatrin, we try to include patients or start them early. Outcome-wise, definitely at least 50%, the usual more than 50% reduction. But I think etiology plays a bit of a role. A big proportion of my patients, I think 70% of them are secondary to post-traumatic brain injury. And I find this group, they don't do very well. Yeah.
For me, infantile spasm was one of the very good types of epilepsy which responded to ketogenic diet, more than 80%, especially in tuberous sclerosis, because we have a direct action again of ketogenic diet on the mTOR, but we have a very good response, and we tried a lot because we have deficiency in vigabatrin in Egypt, so we use it so much. Now the session is closed, and thank you for everybody, for the panelists and for the audience. And I'm happy I was with you in this session. Thank you, Dr. Nathan.
Yeah, I just want to make some announcements. We are still working with the ILAE team, and we've got our expert team here online and on board. And we're trying to fix that problem with the audio of the video recordings. Hopefully we can do it, or otherwise we will be able to do it overnight. And then what may happen is that we will may have to send you a new link to all the panelists and to all the attendees. So we'll be working overnight. I hope not the entire night, but soon. And unfortunately, the ILAE team is all in the US. So that's a big problem. So by the time they get on in the morning, it's already over here late night. But we will try our best, and now we will have a lunch off, maybe till 10 past 2.
Okay.
So that's about 35 minutes. And I would urge some of the panelists who are interested in the next sessions also to stay on. Okay, so good lunch for you. Bon appetit, everyone. Have a good, nice ketogenic diet lunch, which we are having over here. Yeah, butter chicken with kebabs.
Thank you so much.
Thank you.
Thank you. Thank you.
Thank you.